it's very strange for an IC to be a houseful IC, and this is something which is very rare to be seen these days. Now let us look at this fundus photograph, and we all know that this is a case of diabetic retinopathy. Now we want to stage this diabetic retinopathy because your staging is very important, because if it's a proliferative disease, you want to end up treating this patient with a panretinal photocoagulation. But if it's a case of a severe non-proliferative disease where you don't have these abnormal new vessels which are developing, you tend to observe these patients. But the way to identify what stage of the disease is, you want to do a fluorescein angiography, and that is where most of the people will do a fluorescein angiography, identify those abnormal areas of new vessels, and then see that, okay, now this is a stage of proliferative disease which we have, and therefore the patient needs to be treated. But to run a fluorescein angiography in a clinical practice, especially with general ophthalmologists and medical retina specialists, what you require is a trained technician to acquire those images. It's an invasive technique which is dye-based, and it has got a high risk of allergic reactions, and therefore you end up having an anesthetist or an emergency backup which is required in these cases. While a general ophthalmologist requires imaging which is non-invasive in nature, which is non-dye-based, the images have to be easy to acquire, they should be safe with not any exposure to any allergic reactions, they are less dependent on the technicians and the anesthetists, and it also provides an on-first information of the retinal and the choroidal vasculature with segmentation, and also provides a simultaneous OCT scan. And this is what a one-stop solution is what you require, where you have the OCT-B scan and you have the on-first imaging of the OCT, where there is segmentation which is happening at the different layers. So when you look at the OCT angiography of this patient, this is the superficial capillary plexus which is there on the left side, and what you can see is a front or a front of new vessels which are growing, which is suggestive of a foveal neovascularization, and the capillary dropout areas which are seen, and the deep capillary slab which is actually showing you where these new vessels are sprouting out and they are coming from the new vessels. So with this basic information, I'll be talking about OCT angiography, and I'll be actually replacing or substituting Dr. Naresh Yadav, who was not able to come for this meeting. OCT angiography, it basically provides an in vivo 3D vascular information by using the flow of the red blood cells which are in the blood vessels and enabling the visualization and the quantification of the functional vascular network which are there within the microcirculatory vascular beds, and it is non-invasive in nature and it does not require a dye to be injected. So OCT angiography is a wonderful new age tool which tells you a lot about the vascular information and the segmentation through the changes in the red blood cell motion. Now let's talk about the clinical applications of OCT angiography, and let me start with the most common disease, that is diabetic retinopathy. We know that diabetic retinopathy is a disease of the deep capillary plexus, and when you see most of the OCT angiography machines, they give you 4 images which are on-first images. The extreme left being the superficial capillary plexus, then you have the deep capillary plexus, the outer retinal slab, and the choriocapillary slab which is there on the extreme right. Now when you know that the deep capillary plexus is the one which is affected in the diabetic retinopathy, you can see in the second slab or the second image, you can see a lot of hyperreflective dots which are present, or comma-shaped structures which are suggestive that these are microaneurysms which are present, and you can also see that areas of capillary dropouts or capillary rarefaction which is happening, and therefore you can diagnose this case that yes, there is some amount of subclinical diabetic retinopathy which is present in this particular patient. Let me show you another case, which is a 65-year-old patient which being diagnosed with proliferative diabetic retinopathy and treated with diabetic macular edema with anti-VEGF injection. Now you can see here on the OCT-B scan that the macular edema is resolved, but the visual acuity hasn't improved much at all. And when you do the OCT angiography in this patient, you will see a lot of areas of capillary dropouts in the superficial and the deep capillary slabs, which is clearly suggestive that there is an extensive macular ischemia which is developed, and that is the reason why the visual acuity of this patient has not improved despite having a dry macula in this case. Now let's look at another reason why OCT angiography would be useful in a non-invasive way is to identify those abnormal new vessels which are sprouting out towards the vitreous side. So overall, if you look at the OCT angiography in diabetic retinopathy, it is to identify the subclinical stages of DR, it is to identify macular ischemia and account for the poor visual acuity improvement, and also to identify new vessels at the disc and elsewhere. Now let's look at the second common disease which comes to our practice, and this is called as the BRVO, or the branch retinal vein occlusion. And you can see on the clinical photograph, you can see the sclerosed vessels which are present in the supratemporal quadrant, and also those vessels which are extending towards the macula. Now when you look at the OCT of this patient, you can see that the retinal architecture is distorted in the supratemporal region, which clearly suggests that there is extensive capillary dropouts and capillary rarefaction, which is noted in the superficial and the deep capillary slabs, which is clearly suggestive that there is an ischemic variety or an extensive capillary non-perfusion which is developing in these cases. So retinal vein occlusions, whether it's CRVO or BRVO, the OCT angiography is not useful in acute cases because you have extensive hemorrhages in those cases, and in presence of macular edema, the OCT angiography may not be very useful because of the segmentation problems which you will encounter with. What it is useful is in identifying chronic cases where you want to identify or pick up macular ischemia and also retinal neovascularization secondary to a vein occlusion. Now let's talk about another common disease which you encounter in clinical practice, which is macular telangiectasia. And in macular telangiectasias, you basically want to identify the different stages of MACTEL and detect whether you have a secondary neovascularization which is developing or not. So let's look at what happens in the superficial slab in cases of macular telangiectasia. You can see there is a distortion of the capillary architecture on the temporal side to start with. And when you go to the deeper slabs, you can see these abnormal telangiectic vessels which are very well identified on the OCT angiography. Now pigment plaques, which is a stage of macular telangiectasia which is seen in the stage 4 of the disease, is a non-vascular kind of an entity. So you cannot see those pigment plaques on the OCT angiography images, but you can see them in the en-face OCT images. Now the right angle dipping, you can see this dilated right angled vessel which is dipping inside the retina. That is a very characteristic feature of a macular telangiectasia stage 3, and you will eventually see that this is in the outer retinal slab. You can see this entire front of secondary neovascularization or subretinal neovascularization which is seen in the case of macular telangiectasia. So various stages of macular telangiectasia, right from the earlier stage, which is the development of the telangiectic vessels, to the late stages where there is a development of a secondary neovascularization, can be identified with OCT angiography. Now, age-related macular degeneration, that's something very, very important, very commonly seen in day-to-day practice. And what you need to understand, you have the two forms of age-related macular degeneration, the dry and the wet forms. And the dry form, the advanced stages of the dry form is what is called as the geographic atrophy. And then you have the advanced stages of the wet disease where you tend to have the macular neovascularization. Now let's look at a case of geographic atrophy. You can see this entire area of RP atrophy which is seen on the clinical image, but you can see some amount of vascularization which is seen in the choriocapillary slab. The reason why you see those vascularization is because of the RPE loss, and when there is a loss of a tissue, the underlying vasculature, which is the choroidal vasculature, becomes more obvious, and therefore you have what is an artifact, or there is an unmasking because of the loss of the RP, and therefore there is unmasking of the choroidal vessels. Now let's look at the more important ones, which is the type 1 CNVM, which is located underneath the RP. You can see in the choriocapillary slab there is a front of neovascularization which is developing. And then when you do the type 2 neovascularization, you can see that this neovascularization has entered into the subretinal space, and you can see that in the outer retinal slab. And finally, you have the type 3 neovascularization, or which is called as the intraretinal neovascularization, which is seen in the deep capillary plexus. If you look very carefully, this is a very small front of new vessels, which is seen in the deep capillary plexus slab of the OCT angiography. Now, OCT angiography is not without artifacts. It's very difficult to interpret an OCT angiography this. And if you look at this review article, the OCT angiography artifacts ranges from around 72 to 100%, and the most common being motion artifacts, projection artifacts, segmentation artifacts, the masking and the unmasking artifacts, and the flow-related artifacts. Now, these artifacts are primarily can be because of the device itself, the patient, disease itself, the software-related problems, the operator or the technician-related problems, and the abnormal disease-related problems. So I just want to summarize this entire talk with saying that OCT angiography definitely provides a good or useful information of the microvascular network by detecting the changes in the OCT signals due to the moving of the red blood cells within the vascular channels without using an intravenous dye injection. But this is possible if the media clarity is good, if the eye fixation is good, if there are no opacities in the vitreous, if the retinal thickness is uniform and the segmentation is accurate, if there is no intra or subretinal fluids, and if there are no structural changes like heme, hard exudates or plaques, and there is always a corresponding B scan to correlate with the OCT angiography signals. Thank you very much.
Thank you, Venkatesh. That was a nice sense